College and the final of our 3-session webinar series on coping with COVID-19. My name is Cindy Males and I'm I guess I could take my mask off. Sorry about that. I'm Cindy Males and I'm the Public Relations Communications Specialist at the college. We have an informative webinar ahead, but it's important that first we begin by acknowledging that we are in Robinson Huron Treaty Territory and the land on which we are gathered is the traditional territory of Nipissing First Nation. We'll begin this afternoon's session with a welcome from Canada President George Burton.
Thank you, Cindy. Good afternoon, everyone, and thank you for joining us. Northerners continue to rise to the challenges brought on by the ongoing COVID-19 pandemic. Many, especially older adults, are missing their friends and family, and they're feeling isolated and lonely. This webinar series was created to help protect everyone's mental health and well-being. This session will concentrate on older adults and their needs. In addition to highlighting the program supports that exist across the North, you're going to learn about the Village and its mandate to foster a spirit of collaboration between services in the community. It is a student-led, world-class health and wellness facility based here at Canada that we're very proud of. So again, thank you for being part of our event today. I hope you enjoy the presentations, and a special thank you to the organizers who put this series together, and to our panelists for taking time out to join us today to provide your expertise and insights into all those that have joined us. Thank you, everybody. I hope you enjoy the session.
Thanks, George. I'll take just a few minutes to give you an overview of what will happen during the next 2 hours. There will be an opportunity for a question and answer session after all of the presentations. Please use the chat feature to ask your questions. And if you'd like your questions directed to a specific presenter, please name them. Our speakers will respond. Now, let's begin. First of all, let me introduce you to Dr. Joanne Clark and Melissa Tynema. Melissa, I hope I got that right. Dr. Clark is an internist with a subspecialty in geriatrics. She obtained her MD from McMaster University in Hamilton and went on to complete her internal medicine and geriatric training at the University, Western Ontario in London. Dr. Clark returned to her hometown of Sudbury to open and lead the Northeast Specialized Geriatric Centre, part of the regional geriatric programs of Ontario. Dr. Clark serves as the medical lead of this program, as well as being a full-time geriatrician, seeing patients all across the Northeast. In addition to the development and delivery of specialized geriatric services, Dr. Clark's clinical interests include dementia, fall and fracture prevention, frailty, and functional decline. Dr. Clark works alongside a team of professionals to provide regional specialization in geriatric consultations to older adults in communities across the region. As well, she is the chair of the Frail Senior Medically Complex Task Group for the Rehabilitative Care Alliance. She works at the Health Sciences North in the Clinical Testing Unit. She's a medical educator at the Northern Ontario School of Medicine, and she provides support and direction to the Short-Term Assessment and Treatment Clinic in Sudbury. Melissa Tynema is a registered nurse who has provided specialized geriatric services across Temiskaming District through the Northeast Specialized Geriatric Center Outreach Clinic in New Liskeard. She has continued to develop her geriatric expertise by completing her Master of Science in Aging and Health through Queen's University, graduating with an academic excellence. Melissa has also completed a secondment to the Office of the Chief Coroner of Ontario as an investigator for medical assistance in dying. Upon her return to NESGC, Melissa moved into a clinical leadership position to support the implementation of best practices for older adults across Nipissing and Temiskaming districts. Melissa has a passion for lifelong learning, and she's currently embarking on her Doctor of Philosophy and Health Quality at Queen's University. Melissa is committed to contributing to research that transforms health quality for the frail older adult population. Dr. Clark and Melissa will be engaging you through the chat feature, so it's important that you be prepared to answer some questions. That can be done through the chat feature. Please select the All Participants. Dr. Clark and Melissa will be joined by Sylvia Carsgadden. Sylvia trained to be a nurse at Sick Kids in Toronto. She graduated from Laurentian University, and for 13 years, she was the Pastoral Care Associate at St. Andrew's United Church in downtown Sudbury. In retirement, Sylvia has become the quintessential volunteer. And when there's no COVID, she is one of the team captains of Out of the Cold, the hot dinner program operating out of the church. She has been married for 61 years to Terry, for whom she is now the primary caregiver. And with those introductions out of the way, Dr. Clark, Melissa, and Sylvia, the floor is yours.
Thank you. So I'm Joanne Clark, and I'm going to start the presentation. So thank you for those introductions. We've been invited here to talk about the health impacts that COVID-19 have had on older adults. And we're going to spend some time talking about frailty and resiliency and the effect on not only persons, but caregivers living at the moment with COVID. In COVID, the new reality of COVID across Northeastern Ontario. So next slide. We just wanted for a moment to invite people to introduce themselves in the chat. We had made this slide not maybe recognizing that there's almost 500 people registered, and so look forward to what that might look like. But if anyone wants to reach out and tell us where they're from and what their roles are to give me a sense of who's on the line and who's participating, that would be wonderful. Next slide. We don't have any disclosures or financial relationships, neither myself nor Melissa nor Sylvia. Next slide to disclose. And our next slide. Oh, thank you. I'm looking through all the names coming through. I love it. Thank you. Sorry to be distracted, but thank you for doing that. As I see the names, I am seeing them pop up, and I'm seeing your roles and where you're from. So thank you for that. So this is our objectives for today. We want to describe the current context that older adults and their caregivers are living with in Northeastern Ontario. I'm going to just minimize my, I want to see, we're going to talk a bit about how older adults and caregivers are being impacted by the changes, both across the social and healthcare landscapes during COVID-19, and then talk about strategies that we might be able to use to promote well-being of older adults and their caregivers. And then maybe to recognize the challenges, barriers, enablers, barriers to healthcare to help us work through what strategies might be important or relevant. So next slide. So first, a little bit about older adults in Northeastern Ontario. So next slide. The proportion of older adults in Northeastern Ontario, which many of you are aware of, is higher than the provincial average. We have not only a higher number and proportion of persons over the age of 65, we also have geographical challenges. We are widely spread out with many areas that don't have a high density. And so something to think about when we talk about older adults is the care structure that supports them. And so we are going to spend some time today talking a bit about caregivers, but also, you know, in that, care partners are the social structures we've built, PSWs, community support services, informal care partners, family members, and there is a younger group that is necessary in many ways to support that older projection. And with time, so over the next 20 years, the older adult population is projected to rise to be almost 1 in 3 adults will be, 1 in 3 individuals will be over the age of 65, looking to be hitting the 30% mark by the year 2020. And so this older, and the fastest growing group is actually the over 85 population. So we're getting a bit of a shift in terms of what the proportions look like. And this is going to continue. Next slide. Then age is, of course, not the whole picture. Frailty is a concept we're going to spend some time talking about. The frailty has a variety of definitions that we'll look at and talk about what a consensus definition we've arrived upon. Different studies have shown different levels or definitions of frailty and different prevalences of frailty. So for example, there are some studies that would suggest that almost 100% of persons in long-term care have certain degrees of frailty. But if you're looking specifically at community dwelling older adults, the frailty percentage is of course much less. The Women's Health Initiative study statistics done in the United States would suggest about 11% of people over the age of 75 or women over the age of 75 are frail. More recently, the Geriatrics program of Ontario has developed a strategy to look at and define frailty more across Ontario, and their estimates using their methods would suggest that 1 in 4 residents in the Northeast over the age of 65 might be considered frail or have some level of frailty. Next slide. So we may have overwhelmed the chat function, but just to switch to maybe talk about what frailty means to you. And I think everyone might have a different or a common version of what frailty is or looks like. So if you want to take a moment to say, this is what frailty means to me, or what I experience for frailty. And I'll just maybe go to the next slide while people are thinking about that. Let me see if I can bring up the chat function here. Aging, delicate, fragile, vulnerable, at risk of harm. I see day-to-day functioning, some look about functioning, susceptibility to stressors, weak, physically, mentally vulnerable, decline in ADLs, being careful with moving, challenges with living independently. So I see lots, yeah, a lot of common threads there. There's a comment that it's a continuum, it's not a binary state. An increased risk, multiple health issues, great. So I'm going to talk a bit about a few patients or persons that we'll meet. So first of all, we're going to meet Tom. So Tom is 80. He's a non-smoker. He lives alone in his own home. He has mild osteoarthritis of his right knee, to a little bit of hypertension of his in terms of diagnoses. And he's quite annoyed actually last March when he was told to come home and when Justin Trudeau advised all Canadians to return home immediately, as he was just in the middle of enjoying a week-long scuba diving expedition. Next slide. We're also going to meet Mary. Mary is an 80-year-old non-smoker. She lives alone in her own home. She also has osteoarthritis of her right knee. She would describe it as more severe. It's actually causing her limitations in her ability to function. Her family have noticed as well, maybe some mild loss of short-term memory, not a big concern, but something they've started to pick up on a little bit more and more. And she's been housebound for 2 months prior to the pandemic. So she was not in Florida or in a hot sunny place doing scuba diving. She's had more pain, and she does have a daughter who lives locally and assists her with her instrumental activities of daily living. So those are things such as driving and finances, groceries, cooking. So she does have someone around who helps her with those sorts of activities. She does receive home care for physiotherapy, as well as PSW assistance to get her in and out of the bathtub. Next slide. And John's 80, he's widowed. He's a non-smoker. He lives alone in a 1-bedroom apartment in a seniors apartment building. He enjoys daily activities with other tenants in the common area. He has multiple chronic conditions and recently noted as well to have memory loss, but more extensive, such that he received a diagnosis of mild stage dementia. He walks with a walker. He does not have a family member checking in on him regularly. He relies on PSWs for supervision and queuing for bathing. His meds are blister pack, and they'll check in on his meds, although they're not giving him his meds. They'll keep an eye on him and make sure he's eaten on the 2 days of the week they pop in to see him. Next slide. So I think from that conversation, you've gotten a sense of different levels of frailty. So what's interesting about the 3 folks I've just introduced you to is they're all the same age. So age alone didn't tell you anything about these individuals. And a lot of people, when we talk about frailty, will say, well, I'm not really sure what it is, but I do know it when I see it. So the gentleman who is on the beach in this slide is quite like Tom, who just was possibly scuba diving. He's out for a run. He's got lots of nice vitamin D, a big tan. Look at those muscles. Very fit, a lot of vitality in that picture. And then the other gentleman looks potentially a bit more like John. They could actually be the same person, these two, the one on the left and the right. But definitely a bit of difference when you look at the other picture. There's a bit of an institutional feeling to it. You can see that he's in a wheelchair. You see a little bit more squaring at the shoulders, that there may be some muscle loss. Definitely more of a frailty or dependency type look to that picture. Next slide. There is actually a formal definition of frailty. So I think when we looked through some of the chat functions, a lot there that came through in this definition. Wasn't long ago, if you Googled frailty or asked 10 different geriatricians, you'd get 10 different answers. But there was a consensus meeting internationally that was held that agreed on the following definition. So it talks about it being a medical syndrome. So a syndrome typically has multiple contributing features that creates this phenotype or something that looks like something. So a medical syndrome with multiple causes and contributors, and characterized by diminished strength or endurance and reduced physiological function that increases an individual's vulnerability for developing increased dependency and or death. So I saw a lot of that in the chat function. Most would agree that it tends to be a result of deficit accumulation and can be a predictor of poor outcomes. So when you actually break it down, age alone often falls out as being useful in terms of predicting hospitalization or falls or death, but frailty is much more potent predictor of functional decline, of requiring higher health service utilization, of resulting in caregiver fatigue or stress or death. Next slide. And essentially, to drill it down, what it is, it's an increased chance that the wheels are going to fall off because there's now just so many problems. There may be no more room for error, right? That's the other place. So it's this next slide. So this picture, this gentleman, he's biking along. You can see that there's a lot going on with this guy on the bike, that he's just precariously and perfectly balanced. But it may just take a feather to land on that, a bird to swoop by, a pebble on the road, or as you can see from this picture, in this case, it might be coronavirus that has come to destabilize this gentleman. So important to recognize that frailty state will account for much of the heterogeneity we see in geriatrics. So age alone is not a disease. But as you age, there are multiple physiological changes and things that might accumulate that may contribute to frailty. So you accumulate risk factors, chronic disease that might predispose you. You may accumulate disabilities that predispose you. There's different. So age, chronic disease, disability, and frailty, those are all different things, but they're highly interrelated. So not everyone with disabilities are frail, as you can imagine. I mean, we have Olympians who have disabilities, but no one would call them frail. We do have persons who live with chronic disease who are not frail. But the more chronic diseases you develop, the more likely you are to develop frailty. And as you accumulate chronic disease and you become more frail, you have a higher likelihood of having disabilities and reliance on others. Next slide. So let's talk about that destabilizer, COVID. So for Tom actually did okay. He was annoyed, he had to come home, but he learned how to use Zoom independently. He has been able to maintain his social contacts with a few friends and his grandchildren. He set himself up with community grocery delivery. He joined a Facebook group of like-minded travel enthusiasts. He met with his physician virtually to keep on top of his chronic diseases, renewed his prescriptions, and he's able to stay fit on his treadmill. Next slide. So Mary, you know, a little bit less able to bounce back. She was very, very worried about contracting COVID. She actually asked her home care services to stop coming in because she's quite concerned about exposure. Her daughter so picked up the pieces there, continues to support with her basic needs, would deliver her groceries, pick up her prescriptions. But Mary became very afraid to leave her home because of the pandemic, and her friends were no longer visiting, but they felt, you know what, it's just going to be for a few weeks, and so I can manage, we'll manage on our own. Next slide. John, unfortunately, all tenant activities in his building were stopped, so he's now confined to his apartment. And one of the things that we saw happening a bit during COVID is a lot of the personal care services just reaching out to say, do you still want this service? We want to make sure that we're reaching the people we can. We have some human resource challenges. And John said, well, no, I don't need any support. I'm doing just fine. He maybe not recognizing some of the help he did need, and unfortunately started to mix up his medications. His apartment started to appear a little bit more disheveled. He wasn't getting the check-in as much as he was from the PSWs before. And now probably all the activities in the building were canceled, so getting a little bit less exercise. And friends and others used to be keeping an eye on him aren't doing that check-in as much as possible. Next slide. This is just also showing us that frailty is a dynamic balance. So it tends to be a balance between your health assets and deficits. So you can have multiple contributing factors to your frailty state or your resiliency state. There's things that will predispose you, others that might tip you over and precipitate a frailty state, those that will enable it, and others that might reinforce it. So, for example, how good your health is, whether you have some cognitive impairment or not, what are your resources, what are the people around you, your community, your services, do you have a caregiver? Because if you have very poor health or challenges in cognition, you may still be able to do quite well if you have the other resources that might support you. But the more that balance shifts in favor of deficits, the more challenge you'll have in terms of your functional independence, as well as your quality of life. Now over to you, Melissa.
Thank you. So now we have the opportunity to kind of zoom out and take a look at some of the health impacts that older adults experience during COVID-19. So next slide. So early in the pandemic, a version of this particular theoretical graph was being circulated on Twitter, and we've adapted it for the purposes of discussing some of the perspectives and impacts of older adults. And in my opinion, one of the benefits to this illustration and the conversation that ensued over Twitter was that it really considered folks to start to consider some of the longer term impacts of some of the changes that we saw early on during the pandemic. So next slide. So in terms of that first impact, it was really about the immediate response to mortality and morbidity that we saw with COVID-19 that was observed globally. And of course, we saw at that time that there was a dramatic shift in the system towards controlling that pandemic. So really addressing that immediate danger. And we also knew quite early on in the pandemic that older adults were disproportionately affected by COVID. So many of the actions that were put in place were implemented to protect such a vulnerable population from transmission. So certainly one of the, and you can stay on that slide, yeah. So certainly one of the other priorities of this particular curve was to preserve acute care resources. So we know at this time that older adults were encouraged to stay at home, not to go to the emergency room unless there was truly an urgent care need. We saw rehab beds canceled at the time. Many of appointments went to virtual or phone delivery, and we also saw the cancellation of surgeries. Older adults were also dramatically impacted by visitor restrictions, so caregivers weren't allowed into hospitals or residential or long-term care settings. So that directly impacted a lot of the direct care that they were able to receive on a day-to-day basis. We saw limited access to personal protective equipment at this time as well. So in particular, that caused a lot of confusions about trying to safely provide home care visits, as well as community and clinic care visits. And of course, there is a big push for the closure or cancellation of non-essential services. But for older adults, many of these non-essential services are in fact very necessary to maintain their level of well-being and function. So even if we think of something like a falls prevention program, that's needed to maintain their day-to-day mobility and ability to participate in activities. So during this time, while the system reoriented, there was an overall quite dramatic reduction in access to healthcare across the continuum. And that may have been perceived either because of an increased fear of not wanting people to come into their home, or it could have been a reality based off of that reduction in service. Next slide, please. So in terms of the second impact, this was some of the immediate consequences that older adults may have experienced because of those initial changes. So there was continued to be consistent messaging at that time to make sure that you're staying at home. There was continued resource restrictions as well. So many older adults were either unable or again, fearful to be able to access care. So certainly there was examples of older adults having an urgent care need such as an acute exacerbation of their chronic congestive heart failure and then not wanting to present to the emergency room. They maybe weren't getting their regular blood work, even though it was very necessary to monitor their health. And they potentially weren't even going to an assessment center to be able to, even if they had positive symptoms of COVID. And older adults were much more likely to experience more immediate impacts to the cancellation of surgeries. So for example, if I think of an older adult that was waiting for, say, a knee or hip replacement, certainly those folks quite dramatically feel the impact of their limited mobility and are at a much increased risk for deconditioning as time goes on. And overall, there was still quite a dramatic disruption of care routines as there was an adjustment across all services across the continuum. So it was quite challenging at this time to coordinate supports for older adults, either because there was changes in schedules or enhanced precautions that were limiting the amount of availability of appointments. We also saw a dramatic transition over to virtual care during this time, but for older adults, that wasn't always an easy solution because they often lack the technology to be able to engage in virtual means. In rural areas, it became difficult because of broadband coverage, and often they don't just have the digital literacy or the exposure to a lot of these online platforms to be able to easily navigate those types of appointments. So within this disruption of care routines, there was also certain individuals that experienced quite acute changes. And I think of an older adult that does have a diagnosis of dementia and relies heavily on the security of a consistent day-to-day routine. They were much more likely to start presenting with, say, responsive behaviors during this time. So next slide, please. So whereas the first and second impacts really look at the short-term implications of some of the changes that we saw across the healthcare system, the third impact starts to consider what are the long-term consequences of interruptions in care. And at this point, we're starting to see an influx of older adults that have started to experience some negative impacts on physical distancing. They're feeling more isolated in their home, and that's starting to impact their function and their level of independence because they don't have that supportive network around them. And certainly there's continued to be some changes in terms of how care is delivered in the community. In particular, we're continuing to see a lot of the virtual care provisions and also limitations of some in-person visits. And either older adults were quite impacted in terms of their day-to-day function by some of the temporary closures of things like outpatient programs and fall prevention classes, and some of them haven't been able to reopen quite yet in terms of some day programs and so on. So overall, this negatively impacted the health of older adults and has created an increase in the complexity of their care needs because they have seen a decline in their well-being. And a lot of that care has been shifted now over to the care giver or care partner to be able to absorb some of that increase in their care needs or kind of make up for a lot of the lost services that used to be part of their daily routine. And I think you can note from this particular curvature that, this is a long-term impact in the sense that it hasn't gone back to its original health impact, and it certainly requires some direct intervention or support from the healthcare community or social support community to be able to address the needs of older adults. So next slide. So the fourth impact then speaks to the fact that we will see this influx of older adults that are now experiencing changes in their health. So they're more deconditioned, they're more frail. And so now they are going to require some level of restorative care. And I think it's important to recognize also within this influx of older adults that we also can't lose sight of the fact that their caregivers are also going to need some support to be able to restore their own well-being. So when it's appropriate, we really need to focus on being able to reintegrate respite opportunities and day programs. And so certainly there'll be a focus of healthcare and social support providers to be able to identify those older adults that have seen a change in their baseline or their level of well-being, and then take initiative to be able to navigate them to services. So that could be anything, again, from fall prevention classes to physiotherapy to primary care to better manage their chronic conditions, and to directly to provide supportive care and interventions. And Dr. Clark will give us some strategies later on in the presentation. And I think it's notable to point out that unfortunately during this fourth impact, there's a paradox within our healthcare system that although there's an increased need for restorative care, we've lost some of the capacity within our system to be able to respond to this need. So certainly it'll have to be a priority moving forward, both and I would say specifically in the community sector, but also across the continuum to be able to reinitiate some of this programming. And we're starting to certainly see examples of that in terms of some of the outreach programs that we're seeing, high intensity needs funding, and some of the transitional and reactivation care beds. So a key point that I do want to bring across with this slide is that certainly it should be our priority to help older adults to be able to recover and then meaningfully participate in their day-to-day life as much as possible moving forward. Next slide. So overall, I think I would be remiss if I didn't point out that certainly we are attempting to provide this levels of support for older adults in the context of a healthcare system that is quite resource restrictive. So all of these impacts aren't actually sequential, that we don't have the luxury of dealing with one and then getting to deal with the subsequent impacts. Unfortunately, they're kind of layered on top of each other. And certainly our healthcare human resources have experienced tremendous burden in terms of having to navigate this very complex pandemic. But that being said, I think we've certainly seen very notable acts of resilience across many organizations in the Northeast. So we've seen many return to work as early as possible. There's been lots of advocacy in terms of the resumption of care, in particular with regards to face-to-face visits when it's safe to do so. I've seen lots of additional flexibility in how care is delivered. So partnerships, for example, between community paramedicine. There's also been, and I think this is a key point as well, an overall recognition that care for older adults and their caregivers is an essential service. And I think as evident by the number of participants that we have online today, we do have a workforce that certainly is now committed to obtaining the knowledge and having the ability to recognize and respond to the needs of older adults. So I certainly think that those are a lot of points of celebration. Next slide. So how did these healthcare system impacts affect our folks that we've carried through in terms of their story? So for someone like Tom, he was starting to feel some of the psychological burden of a reduced social environment, and he did report feeling lonely, but he has family that's able to compensate for a lot of these changes in his social environment and network. And so they would have been the family that you saw physically distanced and having a great time at the end of their driveway. He also had a much more robust state of health. So the additional commitment from primary care during this time to offer some check-ins, that's been enough to stave off any of the significant negative impacts of isolation. Next slide. But in contrast to Tom, Mary has seen increased vulnerability to some of these changes in the healthcare system. So her knee replacement was canceled, and because of that, her mobility is deteriorating even further, and now she's experiencing significant pain. She also no longer has that opportunity for social interaction that was provided through some of these home care visits or through her informal social group. And she has not fully appreciated the extent of the changes in terms of her physical needs. So she's continued to refuse home care despite the fact that they keep calling to check in and offer to reintegrate their services. And all of her other assessments at this time through all of their providers have happened over the phone. So no one has really been able to pick up on Mary's declining state. So because of this, the burden of care has really shifted dramatically over to Mary's caregiver, which is her daughter, to be able to continue to support her daily needs. So she's doing a lot of work in terms of providing bathing, meal preparation, grocery shopping, and she's starting to feel overwhelmed at this point because of this dramatic shift and increase in care needs. Next slide. And then at baseline, someone like John was much more dependent compared to the others. So he relied heavily on his day-to-day routine for a sense of cueing because of his mild dementia. So because group activities were canceled during COVID, he lost that morning routine of going down to the common area for coffee. And at the same time, he would grab his muffin along the way. But because of that change, he's now forgetting to eat his breakfast. He also required some supervision and cueing for bathing, given his short-term memory loss. And at the same time, as Dr. Clark mentioned, that's when the personal support workers would be providing things like medication check-ins and setting up his meals on wheels. But because no one's coming into the home, John's not always remembering to eat his meals on wheels. And unfortunately, several of the meals are left in the fridge to spoil at this point. So due to all these changes, John has unfortunately had a fall in the bathtub while he was attempting to independently shower. So he was feeling quite dizzy and he called out and a neighbor heard him and called EMS. So when the paramedics arrived, they discovered that John had quite an elevated blood pressure, likely due to the fact that he hasn't been taking his medications. He has several unopened blister packages. They were able to compare his weight previously to what was in his home care book, and he's unfortunately lost 12 pounds at this point. He's appearing quite confused, quite disoriented, and he's very weak. So you can appreciate that at this point, the paramedics had to bring him to hospital because of these tremendous safety concerns. So unfortunately for someone like John, even once he's in the hospital, he certainly could benefit from rehabilitation and restorative care that would be provided to him in that setting. But it's much more difficult to be able to transition him back to community because he doesn't have that strong support network of family to be able to provide those daily check-ins for his well-being and safety. So for someone like John, we can do much better by him, and it's much easier to be proactive when it comes to his care in terms of trying our best to make sure that we increase services because of his vulnerability, and we provide that supportive network to wrap services around him as much as possible. Next slide. So when we follow the stories of Tom, Mary, and John, it helps us to illustrate how frailty can make an older person more vulnerable to an external stressor, such as COVID, and the resulting health changes that can occur because of it. So as you can see from that top green line, Tom was managing well before COVID. So he only experienced a minor deterioration in response to COVID. He was maybe a little bit less active overall, but he's able to return to his baseline quite easily and quickly. In contrast, Mary, who's much more vulnerable than Tom, has experienced changes in function that are more significant. So again, she lost some of her mobility, she needed more help around the house, and it'll take her longer to regain some of her function. So you can see her dip is more dramatic and it's wider as well. And also some of these negative changes that Mary has experienced may mean that she's not able to return back to her previous level of function that she had prior to COVID. But I would argue that for someone like Mary, she certainly would benefit and has an increased chance of being able to return to her baseline with some specific interventions and support from health and community support providers. And then someone like John, unfortunately, sorry, you can see, yeah. John, unfortunately, was teetering on the edge of dependency prior to COVID. So he was extremely vulnerable and had a much higher level of frailty in response to an external stressor. He experienced a profound deterioration, so a much larger change from his baseline. And he experienced a lot of the negative outcomes that we can see associated with frailty. So he had the fall, weight loss, and now he's requiring hospitalization. So he's much less likely to be able to return to his previous level of function and independence. So when it comes to geriatrics, as Dr. Clark has pointed out, frailty tends to be a better defined concept than something like resilience. So we tend to use that language, but I think of resilience as kind of the opposite side of the coin to frailty. So Tom has many more characteristics that were protective of his response to a stressor compared to someone like Mary, or in particular to John. And I also like to compare the definition of resilience to the ability to bounce back. And that's very much in keeping with the American Psychology Association's definition in terms of resilience being an adaptive process rather than it being any kind of personality trait. So while there is kind of high quality literature that's lacking in this area of resilience in older adults, there is some evidence to suggest that there are particular characteristics or strategies that can confer resilience. So next slide, please. So again, for someone like Tom, we can easily see that he has characteristics in his favor to promote adapting well in the face of adversity. So when it comes to the key characteristics of resilience, they tend to be bucketed across physical, psychological, and social factors. So again, Tom was someone that was physically well and robust. He got on the treadmill during COVID. He had a much stronger support system, and he had a great network of family and friends. resilience. And I think it's important to point out that there are some definitions of resilience as well that infer following a stressor, an individual actually has the ability to develop skills and strategies and personal characteristics that promote enhanced well-being. So meaning that they're actually better off after the stressor than they were in the first place, because they've been able to obtain all of these additional strategies and characteristics. And Tom really is an example of that. So he's learned now about additional community supports available to him, such as grocery delivery in the case he needs them in the future. He's also developed skills such as navigating the virtual world. So now when he's able to return to Belize, he's no longer going to rely on his flip phone. He's going to be FaceTiming his friends and family in order to be able to share in the journey of his travels. And he's developed some of the psychological well-being to know that he has the inner capacity and strength to maintain a positive outlook amongst adversity. Next slide. So as we've already heard about John, he has a much higher level of frailty. So he did not have a lot of the characteristics that would support his ability to adapt to a stressor such as COVID. But I think it's very important to point out that despite his vulnerable physical state, John may have done okay if he continued to be wrapped in a very strong and proactive network of health and social services. And we do know from some literature that folks are very much capable of maintaining resilience despite some of these socioeconomic, physical, and psychological barriers. I also like to compare resilience to the World Health Organization's definition for healthy aging, because it points out that healthy aging is more about creating the environments and the opportunities to enable people to be able to be and do what they value most in their lives. And it's less about a focus on their physical well-being in terms of their state of disease or disability. And John really was no exception. So despite all of his frailty, he was very much motivated to be able to stay in his apartment, remain as independent as possible. And that's what gave him his meaning and improved outlook and zest in life. So again, I think it's very important for someone like John, who doesn't have a lot of inherent kind of family social support available to him, that we really have to take creative and proactive approaches to care and coordinate outreach services for him, coordinate and collaborate to get those daily check-ins and wrap him in kind of consistent outreach so that we may have been able to change his trajectory if that was the case. Next slide. So lastly, while Mary had some more characteristics of resilience compared to John, she certainly can benefit from formal health and social support to be able to address her inherent frailty and develop some robustness to help her cope and overcome with some of the losses that she's experienced during COVID, in particular related to her physical health and some of the impacts of isolation. So I think it's important to note that her current state does not have to be accepted as her new baseline. So with commitments from providers, she has the potential to return to her baseline level of health. And I'll let Dr. Clark speak to some of those opportunities.
Great, thanks, Melissa. Great, so next slide. So comes to this concept that frailty is a changeable or rather dynamic state and not always to the worst. So previously, most studies, at least initially looking at things like frailty and functional decline, you take a cohort of folks at the beginning of time, follow them through till the end of a time frame. And on average, definitely there is a tendency for frailty to increase with time, which would give the perception that it's a unavoidable progressive state. But Thomas Gill's group, so this is a group out of Yale, who he's known as the disability doctor, if you follow him on Twitter. They did something rather new where they called people every 6 weeks and did comprehensive assessments every so often for many, many years, looking specifically at frailty and disability. And what they were able to show is that frailty is actually quite dynamic, and so is disability in older adults. So not only are folks who were frail at the beginning, did that state change from time to time, states of disability. So over time, and at least this is in the original publications, most people had at least one transition from being either not frail, pre-frail, frail, or to dying with time. They noted that although transitions to states of greater frailty was more common, so if people were going to change, they were more likely to become somewhat more frail. 1 in 4 of the transitions were to states of lesser frailty. So not to be discouraged, as Melissa was saying, is just because you've had a bump in the road doesn't necessarily mean we can't get you back to baseline. Next slide. So it's important to understand function in older adults. And the challenge when an older adult is experiencing functional decline is teasing out why that is. And it's very different, but it can look the same. And that's the challenge, whatever your relationship is, if it's your mom or your dad, your brother, your sister, if you're the PSW, if you're the care provider, when you see someone who's not doing as well, not functioning as well, it can be any number of items. So we have folks who have functional decline, and it can be because their heart failure is destabilizing, or they're having more shortness of breath, or they've developed dehydration or constipation. It can be because their memory is letting them down. It can be that they've become depressed or very anxious, which we're seeing so much more of now that with COVID and the news and the fact that folks are just stuck all day watching those sorts of things. Falls, mobility loss, pain. If you're in pain, you can't do the things you wanted to be able to do. Medications. So with time, medications tend to pile up. We very rarely make an appointment with our physicians to say, could I just be on less medicines today? Can we just talk about that? You may not need the same amount of medications for your blood pressure, for example, at the age of 80 as you did at the age of 70. But if we don't sit down and reframe looking at your overall goals of care and medical conditions, we don't really spend time just targeting reducing medication burden. Having incontinence can induce your function. I have patients who don't leave their house because they're too scared of having an accident. Or not knowing where the washrooms are. And now in COVID, many places have closed their bathrooms and you can't, there is no access. Nutritional decline, and then the lack of your social support, as we've seen in some of our examples today. Next slide. And so when you're seeing that, we need to really be patient focused. When saying there's something, and it can be overwhelming. So you have an older adult, they might be on many medications, they may have a lot of health conditions, you're seeing them and they're having difficulty managing, and how do you tease that out? You know, I always said geriatrics is much different than pediatrics. In pediatrics, you have these standardized mechanisms of measuring things. You know that at age 6 months, they're supposed to have these speech goals and these motor goals. And at 18 months, there's all these goals they're supposed to hit, but age really has no meaning. So when it comes to figuring that out with an older adult, you have to say, so how were you a year ago? Or what was it like 18 months ago? What's changed for you now? And sometimes just trying to say, well, what's the hardest thing in your life right now? What's the hardest part of the day for you? When did that start becoming difficult, and why? And what's changed? Why do you think it's changed? Sometimes it can be simple things like, well, I had sudden medication, new medications. It can be the loss of a caregiver. It can be suddenly the pain is making it more difficult. If you could just take the pain away. I had one patient example where we had, I saw a family that had just moved their mom into an assisted living, and their mom was cognitively intact. The only reason they made that move is to give her a little bit more social interaction. And within 3 months, she changed dramatically. She had a lot of nausea. She had urinary and fecal incontinence. Her cognition had taken a dive. And I was very lightheaded and dizzy, and I saw her urgently because of all these acute changes. And we went through and recognized that although she was doing exactly very fine in her home before the transition, she probably had a little bit more memory loss than we'd recognized. And one of the things she was not doing was taking any of her medications. And when we moved her into assisted living, suddenly this woman went from taking no medications to taking all of them at once. Well, because her blood pressure had been going up and up and up, and no one knew that she wasn't taking her blood pressure meds, they kept adding more blood pressure meds. So suddenly she's taking all 3 blood pressure agents. Her pressure's super low. She's was prescribed a medication for dementia, but never took it, and then took it at full dose when she transitioned, which gave her incontinence and nausea. And she had a very, very low heart rate because suddenly she was on a medicine that was 2 medicines that were controlling her heart rate. And so really, that was, I mean, that's a rather dramatic example, but it was very easy in her case to say, well, it's her dementia, or it's, you know, she's just getting old. But when you went back and said, well, what was the difference? When did this change and why? Most people do better in assisted living. And we teased that out. We saw that, in fact, that was the reason we'd seen such a change. Next slide. So for Mary, one of the things that we're seeing that for her is she did have some challenges, some pains, some specific impairments. So how did we apply this learning to Mary's situation? Well, to help her out, we did resume her home care services. We were a little bit more aggressive in rescheduling her knee replacement, recognizing that that pain was a significant challenge to her quality of life and her restricted mobility. And this is a key. You want to have your eyes open for people to start restricting their mobility. That same study that looked at transitions and frailty, one of the most potent predictors of people doing poorly or ending up in hospital is if they started to restrict their mobility for any reason, whether it was because of pain or depression or shortness of breath, they lose muscle mass quickly. And so if you see something that's starting to restrict someone's mobility, you need to get on that as quickly as possible. Is it pain? Is it depression? Is it dementia? Is it dizziness? And how do we get you moving again? She was referred, for example, to a falls prevention program while awaiting her surgery, getting some physiotherapy, looking at her environment. How do we reduce her risk of falls? To alleviate some of that caregiver burden, we connected her with some community support services. And now the groceries and medications are being delivered. We're going to take that off of her daughter's shoulders and set her up with the ability to do that on her own so that we can preserve her daughter's quality of life longer. And maybe connected her with a virtual senior center without walls, setting that up through the iPad. So next slide. So there are some, in the literature, some high yield interventions for targeting unfrailing. Exercise by far and away has the best evidence. It works whether you're frail, if you're in the community, if you're in long-term care, if you're cognitively impaired, if you're not, and it doesn't matter what your level of frailty or geriatric syndrome is, this is highly effective. Occupational therapy assessment, especially if it's individualized and targeted to the individual combined with exercise, has been shown actually to reduce function and reduce mortality. I don't know why that is. I have some ideas. Certainly falls and fractures are horrible catastrophic events for my patients, and a hip fracture and vertebral fracture each are associated with a 20 to 30% mortality rate. So I suspect it's at least related to that. We do know medication reviews. So trying to every once in a while just say, let's just look at your meds and see how we can realign and reduce that. It reduces falls and can improve mortality. And then a comprehensive geriatric assessment. So seeing a specialized geriatric team where it looks at all of these domains, cognition, mood, falls, mobility, social supports, and putting this in the context of your current medical conditions and goals of care seems to reduce medication burden, better prescribing, improve cognition, lower mortality, and less institutionalization. Next slide. So in terms of unfrailing, This is a kind of a top 10 list that you may have gathered from some of the comments we've made today. Health promotion, you want to reduce, you want to build a good reserve, so a lifelong approach to good health and exercise. You want to reduce acute illness, so maximize those opportunities for vaccinations. Exercise, good diet, vascular risk factor production will help maintain your cognition for as long as possible. You want to look and identify early any acute or chronic illnesses and make sure they're well managed. Optimize any comorbidities like depression or pain or sensory impairments, hearing and vision that might impact your mobility or function. Back to the exercise. People tend to forget to drink. Thirst response declines with age. And then people may not recognize that they need to drink. And so being on top of that, medication review, and then optimizing the environment as well as community and caregiver supports. So back to you, Melissa.
Thank you. Next slide. So because we were able to intervene and provide additional care to Mary, overall her outlook and trajectory is much better at this point. So her cognition is stable because she's having meals prepared to her and grocery shopping done by her daughter. She hasn't experienced any weight loss and she has a balanced nutrition. Her pain is much better controlled because we have provided her with some medications for that. And so now she's able to optimize for some more mobility to interact with some day-to-day activities. She hasn't had any other falls, and she reports being more hopeful overall. And because we've reintegrated some of those home care services, her daughter's feeling less overwhelmed. Next slide. So when you compare, in particular, Mary's care and her experience to someone like John, what do you think is different about these two experiences? And I do welcome everyone to put their comments or their ideas in the chat. And we can head on to the next slide while people do that. Yeah, so I'm starting to see that support is crucial, and I would absolutely agree. And I see another one pointing out that she had better social support and recognizing the role of her daughter. So absolutely. So really, as some of you have pointed out, Mary needed support to be able to remain at home. And compared to someone like John, Mary had a very local, actively involved family caregiver, which was her daughter, to support many aspects of her care. So Mary's story may have looked a lot different without her daughter's support. Even if she had various check-ins from community partners, it's very hard and difficult to navigate such an unpredictable and complex and ever-changing environment during the middle of a pandemic, especially if you even have a little bit of mild cognitive impairment. So certainly we recognize that the role of caregivers is essential to maintaining and promoting the well-being of older adults, and in particular, allowing them to stay at home and in the community. So Mary's daughter in particular likely falls into the Ontario statistics of someone that's under the age of 50 and caring for a parent with long-term health challenges. And we do know from these statistics that a majority of these caregivers actually provide 5 to 9 hours of support every single week. And based off of a similar group of individuals from reports from Statistics Canada, we know that the most common type of help that they're providing is transportation, and that occurs with 84% of caregivers. And they're doing things like running errands, doing the grocery shopping, and attending medical appointments. And I would probably offer that during COVID, rather than just providing transportation for these tasks, they were likely going out and directly supporting many of these activities in order for the older adult to stay safe at home. And we also know that 64% of these caregivers contribute to tasks such as meal preparation and house cleaning. So you can imagine that without a caregiver, Mary may not have been able to access her groceries and medications, and she could have suffered weight loss then like John. Her mobility and pain may have declined and then increased further, and she wouldn't have been able to maybe stand at the stove to be able to cook herself a meal or keep her house tidy. So given some of Mary's underlying frailty, she could have easily experienced that same slow and steady decline that we saw in John, but really it was her daughter that was able to keep that at bay and support her ability to be resilient throughout the pandemic. Next slide. And I would argue that equally as important, but often not reflected in the reports and statistics, are many of the invisible tasks that caregivers do embrace for their loved ones. So they take on the important role of maintaining the personhood of the older adult, so making sure that their uniqueness, their story, their humanity doesn't get lost amongst like the sometimes sterile healthcare environment. Caregivers also advocate for the needs of older adults, and they hold us accountable as care providers to meet these needs. They also make very difficult decisions about care when an older adult can no longer do so, and they seek information and navigate a very complex system of services. So again, if we think to Mary's story, it was her daughter that helped to advocate to have home care services resumed, help her to set up the senior centers without walls, navigate a referral to falls prevention program, and so on. But recognizing that these invisible tasks are a central component to care, we have learned that from qualitative research that it's actually often these indirect care tasks that are considered a greater responsibility of caregivers, and often they're a source of unalleviated stress because of the invisible nature or burden of these responsibilities. So as providers and support persons, we're very much capable of sharing and supporting some of these stressors or burdens that caregivers experience. So certainly we could take the responsibility of initiating conversations about the person and their story. We can certainly share in advocacy because we have an internal working knowledge of the healthcare system. We can engage in conversations about care early and jointly to help facilitate some collaborative problem solving. And we can also anticipate needs and provide system guidance so that many of these decisions don't have to be made in a time of crisis. Next slide. So overall, specifically outside of COVID, given the considerable effort and responsibility placed on caregivers, we do know that 66% of caregivers experience a high level of stress. And during COVID, unfortunately, caregivers reported even more difficulty managing their day-to-day responsibilities. And I would infer that this was likely the case because care was disproportionately shifted back to care partners, and informal caregiving hours likely increased either due to changes in services or also because of the greater care needs because of a decline in older adults' health. So we do know that we certainly have to acknowledge and recognize the needs of caregivers and not let them become the hidden patient within some of these interactions and relationships. So we do know that providing direct sources of social support, and that could come in the sense of providing emotional support or problem solving or providing information, does help to increase the resilience of caregivers and reduce some of that stress or burden. And it has to be a priority to start to reintegrate respite and home care and day programs to help alleviate those burdens that caregivers experience when it's safe and appropriate to do so. And I do want to make a brief mention because in the absence of the ability to do home visits, we do know that with some emerging studies that are being done during COVID, that video is a better option when possible compared to telephone check-ins, because it was only video that was associated with being able to promote a higher level of resilience and well-being in individuals with dementia and their caregivers. Next slide. So on that note, I certainly could spend another hour reviewing the wide body of literature and resources to explore the roles of caregivers, but I'm going to stop here and I'm going to ask Sylvia Carsgadden to share her personal experience as a care partner to her husband. So thank you so much for agreeing to share your story with us, Sylvia, and now you can go ahead.
Great. Thank you. Thank you. My name is Sylvia Carsgadden, and I'm really happy to be invited to share in this webinar this afternoon. So my husband and Terry and I live in a condo in Sudbury. We have easy access to the downtown and shopping and hospitals. We moved here about 6 years ago when we felt we needed to downsize. So Terry was having memory issues, and just after we moved here, he was diagnosed with Alzheimer's. The first change that we noticed was that he was not driving. So this was very challenging for him because he considered himself to be a very able driver, and he was very upset when he was put off the road, as he explained it. The second change was soon after that, and we discovered that he really wasn't able to negotiate the new learning that was necessary to make the transitions to do household banking and paying the bills and keeping track of events. The third change was his navigation. He got lost several times. He wouldn't want to be wandering around in the mall by himself. That would be a very scary experience. And he's also very hard of hearing. So addressing his hearing challenges takes a lot of planning and time and energy. I would say that Dr. Clark might not agree, but I would say he's kind of in the middle stages of Alzheimer's. He can still, his memory is terrible, but he can still do lots of the things routine sort of things that he's used to doing. We have 3 daughters who live at a distance and a son who lives in Lively. His job is to look after us and do what his sisters ask him to do. Terry is still quite independent. He looks after his own care. He looks after his own meds. He plays golf twice a week in the summertime, and up until 2 years ago, he skied downhill in the wintertime. He does lots of reading. He plays in a musical instrument. He played it in a musical ensemble before COVID. He played in this group, and they would go out and perform at various events. He uses his cell phone, which really is his connection to the outside world, because when he can't hear very well, he finds that hard, but the phone is his way of keeping track of what's going on. He can look up all kinds of information, and he has lots of interests. He watches sports and current events. I have lots of interests too. I'm the quintessential volunteer. I do some committee work for my church. I have lots of friends. I belong to a book club. I like to go out for lunch, and I'm on the board of directors here at the condo where we live. So pre-COVID, we went to church. We volunteered at quite a few things. He helped watch the dishes for the team that we work on for our Out of the Cold team. We played cards with friends regularly. We went to lots of concerts where we would chat up our friends that we knew who went to the concerts too. We'd have friends in for dinner and our family. So he was engaged, and he could converse with folks depending, of course, on the surrounding noise. So then COVID came, and last February, just as the pandemic was getting revved up, my brother died. We made 3 trips to Waterloo last year in the month of February, and finally, the last one to his funeral. It was exhausting, the grief and the sadness. After it was all over, then we were locked down and there was no one to talk to. So my partner, Terry, he isn't much of a talker. He's an introvert, and talking isn't really his thing, and being hard of hearing doesn't help. Over the years, I've kind of learned to talk to other people. I've got friends I talk to, or my family. So the first thing that happened in COVID was that I lost my talking buddies at a time when I really needed them. And even though I knew all this in the back of my head, I didn't realize of how much of an impact it had on me. I didn't realize kind of how dead I was feeling. And it wasn't until a doctor reflected to me that I looked pretty burned out. And my son said the same thing. I knew what I wanted to do. I wanted to do it, but I couldn't seem to get myself out of the chair. And I'd never felt like this before. I couldn't even do what I like to do, which would maybe read a book or watch a movie. I couldn't understand kind of what had happened to me. It seemed to creep up on me, this lethargy and this feeling of dullness. So what got me out of it? Well, it was kind of a miracle. It just happened because of family circumstances that two of our daughters, the ones who live far away, came to stay with us in the month of September. They decided they would try and help me feel better. And they attacked our condo. They cleaned and they tossed and they ordered some new stuff and they spruced me up a bit. At first I was a bit annoyed. I thought, well, it's not really that bad. But then I decided that they were trying to make me feel better and I should just enjoy it and go along with the program. So that's what I did. Gradually I began to feel better. I laughed a bit more. I enjoyed their company. We were playing games, and they cooked and they shopped, and I watched it all, and we talked, of course. So what did I learn? Well, I learned that I better look after myself. We had a conversation with Madeline Sauvé from the Alzheimer's Society, and her main theme to me was, you need to look after yourself. Well, I thought I was doing that, but I don't think I could have been doing the right things. Looking after myself was my big job, it seemed. So I needed to figure out what to do. Well, it's hard because the main treatment for myself was quite limited in the pandemic. There was no church, no book club, no lunches with my friends, no volunteer projects to go and organize, no concerts and outings. There was only Zoom and hours of it. And it didn't really meet the smell test. It didn't give me back my energy. As well, this isolation had affected Terry. He wasn't having the social action that helped him retain his functioning. He began to search for his words and his alertness was suffering. We weren't doing many of the things that we usually did. I was the recreational director in our home. I invited people in. I planned excursions when we would shop, take the wine bottles back, go for the foot care, have the haircut. None of this was happening. Those were the things we shared doing, but now everything seemed to depend on me. It felt like too much at times. So I learned some things from COVID that have helped me through. First of all, it's important to know myself. What makes me tick? What do you need to do to keep yourself feeling well and alive? So I know that I'm a big extrovert. I get my energy from the world around me, from going out doing things, from talking to people. If I have a problem, well, I call up a friend and we go for coffee. And while I talk out my problem, then I usually can figure out what's upsetting me and I can figure out what to do about it. I like to interact with other people. That's what makes me feel energetic. If I go to a meeting, I come home. Some people come home feeling tired from meetings. I come home with 1,000 ideas in my head and I feel pumped up. I like face-to-face encounters, not so much phone conversations. And while Zoom helps, it doesn't really cut it. So I needed to find ways to interact. So in the fall, I started to go swimming with two of my friends in a pool with safe distancing protocols. We have a friend in our bubble who is alone, who comes for dinner about once a week. And sometimes we play games and sometimes he plays the piano for us and we have a little visit. I also go to the gym downstairs in my condo for a little workout. There's no company, but at least it's some exercise. And we're keeping up with Zoom, although that isn't great. In August, Terry had a little TIA, which put him in the hospital, and our family got excited. They they coped with that by developing a communication system to talk to each other. The four of them are in distant parts of the world. One of our daughters lives in Texas. One of the other ones lives in BC. Another daughter lives in Ingersoll. So they live at a distance. This was a good idea to set up this communication system because they were able to share information with each other, and I didn't have to repeat all the details to each one separately. It really helped me. They communicate on Messenger. They have their own group. It's called Siblings. There's another group called Siblings Plus Mother, but they talk to each other on Siblings. They feel disconnected, and this helps. And as a caregiver, they are supporting me as it's another whole layer of support. I realized from our little chat this morning that this is another level of support that's very important to me. They're supporting me as well as Terry. So a month ago, Terry had a fall. He didn't have any broken bones, but he had some abrasions, which weren't very pleasant. And our family mobilized on Messenger. They felt we needed some more support, they said. And we began to get some services. Now there are more people coming in. There are appointments and arrangements to be made, which is kind of an added burden on me. So Terry can still keep track of appointments on his phone. So that's become his job to keep track of his appointments, the people that are coming in. And I stay out of those contacts, and he has a one-to-one with whomever is here to help him. And that's going very well. Sometimes it feels as if my life is not my own. Little by little, I feel as if my life is getting chipped away by the needs of another person. I know I need to look after myself, but sometimes it doesn't seem as if there's time to do that. That's what it feels like. And I think I knew this was going to happen as I looked forward to what might be in the future. I knew this would happen, but somehow it seems to have happened more quickly than I expected. It's kind of crept up on me, and now I find that we are now at the point of having services. Some of this is COVID, I think. It has sped up the decline that has made these services necessary. And here's another thing I need to do, and probably this is my biggest challenge. It's dealing with my baggage. In 61 years, you can accumulate a lot of baggage. You can stuff things, you can ignore things, you find a way to cope, you can learn to compensate. But things are, and you push things down and out of the way. But the dynamics of dementia often take the person back, and behavior regresses. And I found that old triggers and old responses have a way of coming to the surface. Some patterns are hurtful, and it's tough. And walking away doesn't necessarily help. So I'm thinking that a counseling session might be in order to help me get through this particular challenge. And then, of course, you get asked to participate in a webinar like today, which is a really big event with 420 people. And I feel just set up for about a week at least. So what would I want people to take away from today? Well, it would be, well, from my little talk, I don't know what you'll take away from the rest of it, but from what I want to share, it is that it is really important to look after yourself and find ways to be your own person. I don't think you need to give everything away in the process of caring for someone. I don't think you have to give your whole self away in that process. It's a hard thing to do, though. You have to be intentional in looking after yourself. You have to figure out what gives you energy and hope, and then do it. Recently, I read Jan Arden's book, Feeding My Mother. She is so wise, and I found her book so inspirational. I can't use any other word for it. In the book, she talks about gratitude. She gives out practically a whole page on gratitude. Living with gratitude. If you can begin the day with a word of gratitude for something, that can make a difference. That can be a challenge, but it is something that's very doable, and I think it's something that we can all try. And I want to thank the people who asked me to be part of this event today. It's my story and I'm sticking to it.
Sylvia, thank you so much for your honesty. That was incredible. The entire presentation was very informative, and it was a great presentation, so thank you all very much. Up next, Michelin McWhirter. Michelin is the project manager for the Village Collective Impact Project at Canadore College. She has more than 2 decades of experience in quality management and lean process improvement in education, healthcare, and the private sector. Michelin is an influential leader who is relatable and honest, with a reputation and passion to positively influence the client experience. Michelin is a graduate of Nipissing University and holds numerous certifications, including EGAL, creative problem solving, creating a lean management system, and change management. Michelin, please go ahead.
Hi, everyone. It's hard to follow up Sylvia. She was like in a relay race, I would say. She was our, what do you call that? The last person to go, your anchor. So thank you, Sylvia. What wasn't on my credentials is that I'm also a daughter and support system for my parents, and my dad has dementia, and he lives in North Bay with me, and my mom is the full-time caregiver to my father, and my father is currently palliating at home. That's the choice that they made during COVID. So this part of the presentation is dedicated to all of them. And Sylvia, there's so many things that you said that are like my mom's voice, and we also have a group chat with my other siblings, and my children are in it too, the grandkids, and we call ours not siblings, but the pandemic party, because we started it during the pandemic. Also, like you, Sylvia, I am an extrovert and I get a lot of energy from people. So these webinars in Zoom, I agree. And thank you for laughing out loud. Only another extrovert gets the value of somebody laughing when you say a joke. And that's the hardest thing about Zoom, is when you hear nothing. So I also want to give a couple of quick shout outs. I want to shout out to, we have somebody on the line who's from Brazil. I'm like, wow, Brazil, awesome. That's Paula. I also want to give a shout out to my Canadore students who are currently doing placement. You're going to hear about the work that our students have been doing. So I want to shout out to all the Canadore students and all of the other Canadore students who have joined the call today. It just really shows us that this intergenerational concept of supporting each other is exactly what we need at this time. So go ahead, Josh, if you can move forward for me. So I'm just going to talk about a couple things. I'm going to talk about the village today at Canadore College and this project we've undertaken starting in November, the Village Collective Impact Project. I'm going to talk about some of the initiatives. Some of you heard Dr. Clark mention Senior Centers Without Walls. I'm going to talk about a little bit about our initiative around that. And then the most important part at the end is the lessons learned from our intergenerational approaches. I'll spend time there. So first, the village. So the village is it's a world-class health and wellness facility. It's over 38,000 square feet. But more importantly, it's the only model of its kind in Canada where, in an education setting, where it creates a collaborative interprofessional education, integrating Indigenous, Eastern, Western healing and wellness practices. The village also integrates senior and community care with teaching and also applied research. So yeah, just move forward for me, Josh. We're gonna get our timing down, I promise. Josh and I are gonna sync up. So the phase one of the village is this collaborative interprofessional education opportunity for our students. So we have students from different programs all coming together to learn, that's a very groundbreaking approach to education for our students. We have student-run clinics. Some of you may already know about our dental clinic on site, but there are others. We also have specialized Indigenous classrooms in ceremonial areas. Now in phase 2, a lot of you have heard about the village. In phase 2, this is what people are waiting for, which is the seniors living facility. And that's going to be an opportunity for intergenerational living on campus. And it really supports some of the ideas of, in the first part of the presentation, around maintaining people's health and wellness and how that can avoid the need for long-term care. And that's what we hope to be able to show and prove by this type of facility. Next slide. So, so the village applied, or Canadore and the village applied for funding from the New Horizons for Seniors program, and we were successful in our proposal, and we received nearly $2 million in 2019 in November. And I call it BC, before COVID. It's like a different time. But we received the money then in November, not knowing what was obviously coming so close. But that $2 million is for a 5-year project. And the goal of this project is to reduce the risk of isolation for seniors and Indigenous seniors living in our district, which is Nipissing Prairie Sound, and using intergenerational approaches so that we can increase social awareness and participation by seniors, families, and caregivers to improve outcomes and develop new models of healthy aging. So this project is a collective impact approach. And what started in November was the outreach component to this collective impact approach. Next slide, Josh. So the project, this is the evaluation framework for the project. What we want to have as an outcome is that in Nipissing Prairie Sound, that we are all working together. And when we talk about all, we're talking about agencies and people who support people with, who are older adults themselves, all of us working together. Everyone knows what's available in our community. This is our vision in the next 5 years. So everyone knows what's available. And students are prepared for real world experiences. So when our students are graduating, they are prepared for the reality of the workforce. And Dr. Clark actually gave us some statistics around us being older than the provincial average. So like North Bay, Nipissing Prairie Sound District, we're amongst the oldest in the province. I think we're 28% are over 65. So our students need to be prepared for that reality for when they graduate and what that looks like when they move forward in their careers. So next slide, thank you. So what's next for the project is we're going to be bringing the community together, not in the way that we had imagined it BC before COVID. We never imagined that we would be doing a community event that would be virtual, but that's where we're heading in the first week of March. So we're going to be meeting with older adults, families, caregivers, our students, and cross-sectorial representation from organizations to have this intergenerational summit on social isolation for seniors. And what we want to ask, the question that we're going to be asking and working through in that summit is, what can we do in the Nipissing Prairie Sound District to change the experiences of seniors and caregivers in our community? That's the goal at the end of the project, is to change our experience. We're going to present data at that summit. We're also going to share what available resources and supports already exist. And the goal of that is to basically create a shared understanding of the issues we face and the shared vision for the change we want to see. And that's done through this idea of a common agenda. So we were trucking along with the project and just hiring project staff in February when COVID hit in March. And so I found myself, like a lot of you, and sent home and working from home. And here I am, a project manager for reducing social isolation. And all of a sudden we are facing social isolation on a global level. And so we were thinking about, how do we right now as a project support our community in this time of crisis? We can't just wait. We need to do something now. And at first we thought very small scale. Kelsey is my counterpart, and it was like, maybe we can start making wellness calls to people in long-term care because they had been locked in and we knew they wouldn't have access to family. And then we realized that our students were also facing some crisis at that time where all of their placements were put on hold and they weren't able to complete and graduate at that time. So we thought, how do we unleash this student, what I call the student army? How do we unleash this group of students to support the community real time during this pandemic? And this is where these COVID initiatives were created. So these initiatives were created twofold: one, to support the community in the greatest areas of need, but also to support our students and their learning and provide them with virtual placements. And so all of these initiatives I'm going to talk about are supported by our students from our health and wellness programs like social service worker, mental health and addiction, recreation, rec and leisure, rec therapy, and other programs. So the first initiative is called the Village Cares, and we have our students right now who are doing social check-in and social wellness calls, where they call our people in need in the community to do check-ins. So that started back in April and is still ongoing. We're on our third cohort of students. And the students provide social and recreational contact. They also can do a caregiver check-in, where if you're like Sylvia and it's her husband receiving calls from our students can speak to Sylvia and just get tips and tricks on, like, you know, how are things going and what sort of topics would be best to engage, and we work together that way. We also do what's called like a cyber buddy concept, where our students will help seniors get online and use Zoom. If they have some experience, our students can help over the phone to sort of help them get really more proficient at Zoom. So our students do that. So that's our first initiative. The second is our Disco Hub, which is with the YMCA. This is an idea that the YMCA came to us to help support, and it's a face-to-face program. Right now, obviously that's on hold, but prior to COVID, prior to this lockdown, we had developed this to be able to be delivered outside during the summer lockdown, so we could still meet and support people in learning how to use technology. And that program has been very, very successful, and it's our students who provide the one-on-one support. Next slide. Thanks. So then we have the Senior Centers Without Walls. You heard it mentioned a couple of times during the first part of the presentation. So Senior Centers Without Walls is a telephone-based program that gives people the opportunity to join in by dialing in a number, join into different sessions. It could be a bingo session, could be a wellness seminar, could be recreational activities, and all from the comfort of their home. And so when you register for this program, it's for anybody who's 55 plus, it's free. All of these initiatives are free, and seniors can connect to other seniors also in these sessions. So that has grown. I can't tell you, it's grown, and I know it's going to grow even more. The last thing we have going on right now that I wanted to share with you is our Photo Voice group. It's Photo Voice Aging Unfiltered. It's with a group of women from Living Fit, Women to the Power of 10, and that's Harriet Madigan's group. So shout out to my Living Fit ladies. And if you were to, when we were talking about the frailty scale and the different, the same age people and what's happening, the Living Fit ladies represent that group who have shown tremendous resilience and are experiencing that blip that we saw from that first person in the presentation. I think it was Tom, and then have bounced back very quickly to adapt to the scenario. And so they're doing a Photo Voice group right now where they're taking photos and they're sharing what it's like to be aging in this region, the barriers they face, the experiences they're having, and more importantly, from their lens, what the opportunities are. And that information and that photo voice project is going to be shared at that community event. That is going to help us really understand, like what we heard from Sylvia, the actual experience of aging in our community, not just by data on a piece of paper, but by the stories that our older adults want to share. So I wanted to get to this quickly. This is a lesson learned. And as some of you may have seen, we are going to be sharing these PowerPoint presentations. And I did want to, you know, skim over that, but I wanted to spend a little more time here. So here are some of the lessons we've learned. So I'm part of a network of projects across Canada. So Canada's Village Collective Impact Project isn't the only one through New Horizons for seniors. There's 22 other projects across Canada. And what we heard was two of the biggest barriers to inclusion facing adults across Canada, and it's not the two top, but the two of the greatest are transportation and access to technology and digital literacy. For Nipissing Parry Sound District, it's obviously the same. Transportation, and I wrote down that it's multifactorial. If you look at our Nipissing Parry Sound District, people experiencing transportation issues changes depending on the scenario where they're living and what their reality is. But access to technology and digital literacy is huge in the sense that, again, multifactorial. It could be not even having access to Wi-Fi, not even having access to a device, let alone learning how to use them. Or it could be just learning how to use them as a challenge. Just a little bit of data for our region, about 25% of the seniors in our area live below the poverty line. Again, higher than the provincial average. So this affects the areas of transportation and access to technology and digital literacy. And so these are the pieces of information that this project is hoping to share. But I wanted to share with you those are the two biggest barriers. Prior to COVID, the number one barrier facing our seniors, when I would ask organizations, what is the biggest barrier to inclusion for the people that you support? And transportation was the number one. COVID has brought up access to technology. So those are the challenge, or sort of the barriers we're facing. I want to move into what we've heard from the people that we've been supporting. So lessons learned from our intergenerational engagement are that this isn't a one-way street. When our students started providing support back in April, very early days started reporting that they felt valued, they felt the interactions were reciprocal. The students themselves were also facing isolation. They were also facing, not having contact with family and friends. And so now they were reaching out to an individual who, also was facing the same challenges, but also had a lot of life experience to be able to share with our students. So all of a sudden, this was a win-win reciprocal relationship and not one directional. The second thing we've learned, and I learn it all the time, I'm humbled all the time in the work, is our great ideas are not necessarily what seniors want. So ask them. I know this sounds like, yeah, of course, but I think when a lot of us are doing the development of services, we often go ahead with great ideas. And I can give you a quick one. So for Senior Centers Without Walls, we had this amazing idea that one of our culinary students was going to host a half-an-hour session on Senior Centers Without Walls to do a cooking session, to do a class on how to learn, or a session on how to make biscotti. Do you want to know how many seniors registered or came to that session? 0. Why? Because the people did not want a cooking class. What they wanted was educational sessions and opportunities for learning. So we came up with the idea, we went ahead, we didn't vet it through the people registered, and that great idea isn't what they really wanted. So I see that we're getting close. So we have some questions. I'm just going to go to the last page because this is what I want to leave everybody with. so that we have time to answer the questions. My biggest lesson learned, and this is what I want to leave everyone with, is that older adults and seniors do not want to be helped. And just let that sink in for a second. It's not that they don't want to be helped. It's first, they want to be valued. So if we skip to the last page, I'm going to ask you in chat, I'm going to ask this question to you. What does that mean to you as a provider, as a somebody who supports? It means we listen, you know, it means we ask, it means that seniors are included. We understand the barriers, we value their knowledge and experience. And for me, what I can tell you that it's changed for me is, how do I value my father as he's going through the process of dying, and how do I support my mother? It's first to see not the burden that my role plays, but the blessings that I have every day. And so when I come from that lens, it transforms my experience with my parents. And so on the last slide, there is an opportunity. I see a lot of people are asking about getting involved. Yes, I will respond to emails and to opportunities for anybody who wants to become involved in the project. And there's opportunities for individuals, organizations, and so on to become involved. And then for any of the services, it's a simple email or phone call, and people can self-refer. And again, they're free. You just need to be 55 plus, and we will get you connected. So I'll hand it over to Cindy so we can start looking at questions.
Thanks, Micheline. That was very informative. And I've sort of worked behind the scenes with you on a couple of these things, so it's really cool to see how they've progressed from where we started. We do have a bit of time for questions, and we will go over time if required. The first question is for you, Micheline. Is the Disco Hub program still going on during the lockdown, and are there any plans to implement this program in any parts of the region, any other parts of the region?
Yeah, we actually have had a Disco Hub with West Nipissing in Cache Bay prior to Christmas. We've had one in partnership with the Y in Sudbury, and we've offered several sessions here, and we are going to offer more. With lockdown and us not being able to gather indoors, we're not able to do it right now. Because of the weather, we can't do it outside. That's what we were doing in the summer. We were able to, despite lockdown, do it in the outdoors. So we're going to move to that again. We'll start planning for additional, but we know there's nothing that replaces face-to-face learning, especially learning a new skill like digital literacy. And we also give the people joining access to a device to practice. So.
And for the panelists in general, is there program funding for tablet rentals for seniors? Is there anyone that can take that question?
I do know of one, and I don't have it in front of me. I will make sure is there a way for us to share a link to something like that after this, Cindy? Because there is an organization that people can apply for access to devices and to internet that is being offered now to older adults.
We do have, I see in the chats, Temiskaming Health Unit has a program in place. But we can provide access. We can provide that link, sure, absolutely.
This just feeds the point that I was trying to make, is that we don't even know what is available in our own districts yet. That's what this project is about, is getting us all to align so that we all know what's available. So thank you for that, Lorna.
Perfect. Is there any research being done on the impact of COVID on the health and mental health of seniors and older adults? Perhaps Dr. Clark or Melissa, you could take that one.
Here, let me try to make my camera work too. Here. Oh, it says my host stopped it. My host will have to let me in.
Oh.
So start my video. Here we go. So yes, it is. I mean, I think it's ongoing. Anecdotally, we're seeing higher rates. I mean, I would say depression, isolation, anxiety is the highest I ever have experienced. Not in my patients only, also their caregivers and care providers and care partners. It's been and the challenge on top of that is that all the tools that we had to help people with that have been shut down or canceled. And so it's really, I would say, a time like no other that we've had to experience and try to be creative. We're additionally challenged by our weather. You know, as a geriatrician, the winter has always been a challenging time. As I mentioned, restricted mobility is a scary thing for a geriatrician. As soon as people stop moving, they lose ground quickly. And so we always just try to get folks through that winter period, and we devise plans in October, November. How are you going to stay active? What are you going to do to get through these months? But now things like mall walking, for example, are not things that are available to anyone. And exercise is so important for mental health and cognitive preservation. And so there is research out there. I think we can all tell you that COVID has had a very significant impact on older adults' mental health, the isolation, and also the fear of it, the fear of COVID.
I would echo that. Just to add on what Dr. Clark said quickly, again, across the province, fear came up as a huge barrier to inclusion, as mental health challenges and supports not being available in the way that they used to be. And that's some of the data we're going to present with the project. We hope to inform some of this information as well.
And Dr. Clark, as someone who works in this field, what do you hope happens with the research that's being done so that we can learn from what Northerners are going through right now?
I'm always a very practical person, so I want research to give me answers, solutions, workable things. So to the question of if technology, the vaccine will be sometime yet, and even with vaccination, it will be a while before a herd immunity, and then there's this question of the variants and will there be protection. And so I don't foresee this being over soon. And so I think we need to develop strategies that are going to help for quite some time. And so for I always want to know not only the why, but the how. And so can we get for the tablets into people's hands? What we switched to completely virtual visits for the first part of the pandemic. And I got to tell you, I had a team of people, setting up our patients with virtual tablets and learning, and again, can we get the broadband? Can we get in? Can we do it by telephone? And how effective is it? And I agree with Melissa saying, the video is much more effective than the telephone. And so how do we get that resource into people's hands? How do we do it safely? Some people's homes are not safe spaces for them in privacy. No one wants to really share their top secrets with others present. And sometimes if you're in a small house or a single apartment, the privacy. So how do we get them the privacy they need to be able to share? And how do we access? How do we get folks accessing the supports they need in more creative ways? I need practical solutions. Well,
is the region resourced to respond to the needs of seniors and caregivers as we recover from the pandemic?
I'm not sure it was resourced before the pandemic. So no.
Can you explain why someone with
Dr. Clark on that?
Sorry, Michelin, what was that?
So if I could just virtual high five to Dr. Clark on that.
And I think the human resource issue has been really one of the most challenging. Human resources. I have more people waitlisted for services now than I think I've ever had. I would have to say there is all this funding coming down. There is very unique programs, high intensity needs funding, creative funding, community paramedicine funding that we're working with and we're aligned with. But the funding is not changing. That money is money, but it doesn't. You need bodies on the ground. You need skilled workers. You need people trained in geriatrics. We need folks who have that specialty training and awareness. And to get the boots on the ground has been, I think, the most challenging thing in the last few months, I would say.
Can you explain why someone with early cognitive and memory issues starts to retreat from social visits or gets quiet and does not participate during conversations?
Oh, I'm much happier to answer that question than the resource ones. Yeah, so one of the earliest, so most folks, as they develop a dementia such as Alzheimer's disease, you can also see it in vascular type dementia. One of the most common symptoms is actually apathy. It's not one we talk about a lot, but very common and often predates even the memory loss. So apathy is just a loss of initiative. So I try to explain to my patients and caregivers is it's like the engine, it can run, but it's lost its ignition switch, or the ball, it'll roll if you kick it, but if you don't kick it, it'll sit there all day. So there's that initiative. So one of our first questions is often, instead of, are you more forgetful or repetitive, it's have you given up activities? Do you find they have a tendency to want to stay home more than to go out and do new things? Are they, and then the other piece is folks can have more difficulty with multitasking. So if there's competing stimuli coming at them, it's easier to shut down, and conversations can occur at a fairly quick pace. I talk fast. I have to really think to slow myself down. And if two people are talking at once, which often happens in a back and forth conversation, you'll see them often try to just sit back and disengage. But if you re-engage them, able to have that conversation in the to and fro, it can often be misconstrued as depression, or we have to make sure it's not depression, because that's something else that can happen. When folks get depressed, they can also retreat and disengage. But most of the time with early stage dementia, even before the memory, you'll start to see that initiative. And it can get worse with time, such that simple cues and encouragement originally can work. It's time, let's go for a walk now, to it's time for a walk. And sometimes you have to move it to physical cues. It can stop people from eating or drinking. So you have to be aware of it and put those cues in place. So for example, our Mr. Tom or John, the gentleman who had the more frailty and dementia, the loss of those cues, they'll not initiate it on their own. And so you have to be aware of that.
Okay, this question has just come in. How would a caregiver, a first-time caregiver, find help with helping an elderly uncle with his mobility and steady decline with his mobility when he refuses to leave the home for fear of contracting COVID?
Melissa, do you want to take that one, or do you want me?
You can go ahead, Dr. Clark.
I can do parts of it. It's not easy. There's some different strategies. There are, again, virtual. There's virtual exercise. We actually had at one point, and if Shane is on the line, she can maybe help me with this. We actually had an information sheet early in the pandemic where it was all resources. There's a physical activity center, is it Waterloo Wellington, that had resources online. There are online videos that you can do with them. Home and community care does have physio that will go in and teach a home exercise program that works only if the person will continue to do it. It's much better if there's a caregiver there who can do it with them. We can also teach PSWs if they're going in to do personal care to do the home exercise program, and that can be part of their care plan to continue to do that. I'm trying to think any other tricks, Shane or Melissa?
I think you covered most of it, Joanne. I'm seeing a shift now early in the pandemic. You know, a lot of our exercise groups stopped and they just couldn't run anymore. And we're trying to figure out whether to move online, whether not. Now that this has been so long, I'm seeing more and more groups pop up with virtual options. You know, it's as we know, it's not the same as being in person, but sometimes a safer option. And in fact, some suggestion that people are enjoying it who have a lack of transportation and who can't regularly get to their exercises or find that challenging. It's opened up doors for some folks that maybe couldn't access before. So we are seeing a shift. You know, as a physiotherapist myself, nothing beats being around people and exercising at the same time. But for now, those virtual options are a good substitute, or at least an option for folks.
And I forgot to mention, someone in the chat did the Minds in Motion program through the Alzheimer's Society. So that is a virtual exercise group for folks with cognitive impairment. And so that, and their caregivers, and many of my patients enjoy that.
Yeah, many of the participants have been putting links to resources in the chat, so be sure to check that out. Another question that's just come in. I recently read that excessive earwax buildup can also be linked to cognitive impairment and dementia. Is this statement accurate?
I don't know that it's as much a cause. My impression from my readings is that hearing impairment is a big problem in terms of comprehension. I always say there's a number of ways to make a memory, but a number of requirements for making a memory. You have to be able to attend, focus, you have to be able to get it in code, and then you have to be able to retrieve it. So several steps. There are several things along the way that can disrupt that process. It doesn't always mean your hippocampus or your encoding mechanism is damaged, which is what happens in Alzheimer's disease. You can't encode. But there are many things that could impact that process, hearing impairment being one of them. Wax buildup is one of the first things we look for when people are having trouble processing information, retaining information, or repetitive. So one of our questions is, are you repeating yourself, or are you asking the same questions over and over again? Well, it may simply be because they can't hear the answer, and that's a simple trick. I'm not aware of it being a causal effect of dementia, but more it can worsen symptoms or present with people being worse than they are because they can't hear.
Okay, thank you. I don't see any further questions coming in, and we are just about over time. So that's all the time we have for this session, and we hope you have enjoyed it. This wraps up our seminar series on COVID-19 resilience. Thank you to all of our participants and presenters. We have one last thing to ask of you, though. After the session, you will be prompted to complete a questionnaire. We are really looking forward to your feedback, as it will be useful in planning similar events like this in the future. If you have any further questions, comments, or suggestions about a future webinar series, please forward them to Lisa McCool-Philbin, Canada's Dean, Faculty of Human and Social Science, at lisa.mccool-philbin@canadacollege.ca. Thank you again for joining us today. Have a great day. Goodbye.